I think we're going to get started because there's a lot to cover. Welcome to the ASHA Convention. Welcome to Seattle. I used to live here, and welcome back to my used-to-be hometown. If you attended the foundation event last night, thank you for supporting the foundation. That's really important. All right, so let's get into it. We'll do our little poll again. How many people are actively working with cochlear implants as part of their practice? Okay, good. How many people haven't touched a cochlear implant since graduate school? Okay, good. Are you all audiologists, or did a speech pathologist sneak in here? How about an ABT? Okay, good. All right. Well, we can speak freely. No, I'm just kidding. All right. So I am currently a staff audiologist at AB Staffing Solutions. I'm an itinerant, so that I go here for 6 months, I go there for 6 months, whatever. I've worked in a lot of different places. I've probably worked in every aspect of audiology that there is. I'm also a subject matter expert for a couple of consulting firms that are hired by venture capital folks who all think that getting into the hearing aid business is going to make them $1 gazillion. And then they talk to me and they're like, maybe AI, I don't know. I'm a volunteer board member for the Association of Adult Musicians with Hearing Loss, and I'm a volunteer editor for Mama Who Hears. Does everybody know about Mama Who Hears? Michelle Lappin, who's a pediatric audiologist in San Diego, who is a bilateral cochlear implant recipient herself. She is the poster child for early intervention and what happens when families treat hearing loss. We don't treat the kid. She's got a fantastic website. She's got a great Instagram presence, and she makes the coolest pajamas with little cochleas on them in all sizes. It's amazing. Anyway, that's all my disclosures. Okay, so here's the big disclaimer. I am not here to bash anybody. However, for the last more than 20 years, since my undergrad program, I have been going to consumer workshops, conferences, support groups, that sort of thing. And as soon as cochlear implants hit the market, I started hearing complaints. Not because y'all are terrible people, and not because the technology was terrible, but because of access. So what we're going to talk about is based on over 20 years of me hearing from current and future cochlear implant recipients about the process, okay? It does not represent anybody that I work for, or ASHA, or anybody else. It's just my big loud mouth up here, okay? And I'm not challenging you. I'm not criticizing you. I'm not criticizing your graduate program. I'm criticizing the status quo. Now, it's very interesting to me because in, 40 years, has any technology that you use now changed at all? Sure. But with cochlear implants, the process really hasn't changed that much, and that's what we're going to talk about. Okay, so then you're like, well, that's great, but who are you? Right? So I am a PODA, a parent of a deaf adult. Hey, if he can, have his own acronyms, I can have mine. But he doesn't have a CI, and there's a lot of reasons for why he doesn't have a CI, none of which reside in his audiogram. I did my first cochlear implant evaluation in 1999. I know half of you weren't born. I don't want to hear about it. I've been actively working with cochlear implants in my regular practice since 2009, and I've run programs as large as VA medical centers that served half of California to smaller programs. I'm constantly involved in CI work group, support groups, and as I said before, I'm a board member of the Association of Adult Musicians with Hearing Loss. So here's the problem. 12% of potential candidates get evaluated and receive cochlear implants. Now, we always hear about the 20% problem with hearing aids. However, this is a little bit more of a problem, and we're going to find out in a second. If you meet criteria for cochlear implants, by definition, well-fit hearing aids no longer provide you with adequate speech reception in order to function in daily life. So if you need a hearing aid and you don't get a hearing aid, that's kind of a problem. If you need a cochlear implant, you don't get a cochlear implant, that is eliminating your ability to participate in your life unless you decide to change your communication mode. All right, I'm a little passionate about this. I'm going to warn you. And here's the problem, okay?
The microwave caused static in the television picture. Her shopping carts always had a wheel stuck.
That's quite a mug you have. The scruffy nose can be unable to taste.
There was no place to park.
He would follow his horse in someone's life.
Today we celebrate a chapter of civil rights. I see the competitions have already made. We wanted to achieve that this is your right.
We would not change it without you.
That's about 60% on an AZ bio. That's just barely meeting criteria. That's how some of your hearing aid patients walk around the world every day. That happens over a very long period of time, very gradually, and 12% of the people who live like that end up getting an intervention that can get them to 80 or 90% word recognition in quiet and 70 to 80% word recognition in noise. That's the problem. That's why we're here, okay? All right.
The mic.
So the problem is not that cochlear implants don't work. We know they work. They're no longer experimental. They're no longer risky. None of the stuff that you learned in graduate school, even if you're young, is true anymore because it's rapidly evolving technologies. We now have CT-guided insertion of electrodes to prevent tip foldovers, all kinds of great stuff, right? But the problem is that we still have a subspecialty center-based default for getting a cochlear implant in many, many cities, in many, many states, all right? So these are universities, teaching hospitals, ENT practices. None of that's a bad thing. Those are good places to have for 12% of the people who need cochlear implants. People find out about cochlear implants not usually from their hearing aid audiologist. That's a term we're going to use today. This is an audiologist whose primary approach to treating hearing loss is hearing aids. In Europe, they actually have something called a hearing aid audiologist, which is what we call a hearing instrument specialist. It's a whole other thing. They learn about it from other people who have cochlear implants. They learn about cochlear implants and they get referred finally because somebody, either a physician or an audiologist or somebody said, not yet, not yet, not yet. And finally somebody at an HLAA group meeting. Everybody knows HLAA, Hearing Loss Association of America? Okay. Or ALDA, Association of Late Deafened Adults, or the American Cochlear Implant Association website. They figure this out, and sometimes we get involved. So I have a friend here in Seattle who is a cochlear implant surgeon. He's also a bilateral cochlear implant recipient, another one of these poster kids. I don't say that to him because his ego is big enough as it is, and we got to keep him under control. But no, he started medical school with hearing aids and realized he wasn't going to make it, and so he got cochlear implants. Anyway, this data, it comes from him. The majority of cochlear implants these days are still performed by neurotologists. Now, back in the dark ages, when I started working with cochlear implant surgeries were about 9 hours long. I'm not exaggerating. There was a neurologist, there was a neurosurgeon that took half your head apart. It was a really big deal. Now, it's not. So look at this distribution. This is not like 50 neurotologists in the Dallas-Fort Worth area. It's 50 neurotologists in those 4 states. Okay, now, look at some of those states. Are those places where people have lots of disposable income where they can go and spend 3 or 4 nights in a swanky hotels? No. All right. Look at the plains. 36 neurologists for almost half the country. Is it any wonder we're at 12%? But here's the problem. There's 482 neurologists. There's 12,000 ENTs. Can a general ENT do a cochlear implant surgery? Don't. Well, maybe they can, maybe they can't. If you're working in higher complexity populations, probably not. But we're going to talk about that. I see you shaking your head. Are you an audiologist or an ENT?
I'm an audiologist.
Okay, good. We have hope. All right. So one of the biggest providers of hearing aids is the VA. Everybody knows that, right? A gazillion hearing aids. VA pays $950 a pair for premium hearing aids. Okay, so based on some data that I was able to shoehorn out of them, there's about 1,370 audiologists, 410 hearing techs. Some of those hearing techs, by the way, are now licensed hearing instrument specialists. So the VA has kind of figured out there might be some lower complexity hearing aid work that we could do if we had an independent practitioner, and that might help us out, right? 98 audiology clinics in the VA do not provide cochlear implant services, right? So they have this thing of surgery centers and evaluation or programming centers, and as of 2020, we're really not looking at that many, right? So when I was in Long Beach, California, I got handed the cochlear implant program when somebody quit. And I started looking at why we were doing so few. It couldn't possibly be, particularly in 2018 when a lot of the Vietnam era guys were finally coming in, it couldn't possibly be that we only had, 6 or 8 a month. This couldn't possibly. So we started to do some data analysis, and we found that in 2018, there was probably 10,000 veterans who probably at least needed an evaluation, if not probably needed a cochlear implant, and 300 got them. Shaman and al. Did a study where they really looked at the geographic disparity of cochlear implant services within the VA. And this is kind of the problem and why they did the study. So the green are all the cochlear implant, all the audiology programs within the VA. That's a lot. There's a lot of them, right? That's pretty good, right? Pretty good coverage. 1,300 audiologists over all those green dots. The amber dots are the programming centers. These are places that the VA has deemed to have permission to evaluate somebody for a cochlear implant and to program the cochlear implant. The red dots are surgery centers. They do evaluations, but they also do surgeries. And then the blue dots are Department of Defense. So when I worked at Nellis Air Force Base, we did cochlear implants for the VA in town because they didn't have an ENT, but we had 3. And none of them were neurologists. And 2 of them did cochlear implant surgeries. Imagine that. We're going to put a pin in that. All right. So when you look at, I have 1,300 audiologists, but I really only have about 50 that I'm allowing to do cochlear implants because cochlear implants are special and scary and hard. In the VA, they're also GS13 versus GS12, so that might be one of the reasons we segregate them. Then you'd be having to add 160 plus new patients to some audiologists that don't normally see those patients. But if we say, look, 1,300 audiologists, when you read the job description for a GS12 audiologist, it says proficient in the full scope of contemporary audiology practice. Guess what? That includes cochlear implants. So if all of them were trained, mentored, and kept up with cochlear implants, then 7 of their own patients that they're already seeing and failing to meet the needs of could get cochlear implants. Okay. So this is what my buddies at the support groups tell me. There's limited access geographically because all the places that do cochlear implants are here, here, here. There's a weird distribution in the Midwest that's connected to universities, and that's particularly problematic because the distances are so great. They have to wait forever just to get an appointment. And then some of those subspecialty clinics are not keeping up with some of the newer research on how quickly we can activate and how many appointments we need and how many tweaks we need and all this stuff. So they tell me that they're hearing aid audiologists, they just don't know cochlear implants. But their cochlear implants audiologists don't know them. Because they get referred. They meet you, hey, I take a case history, and I might see you twice or 3 times a year, then I'll see you once a year for the rest of your life. But they also may or may not know current hearing aids. So they might not be able to make an adjustment to a hearing aid that you got from your cochlear implant audiologist that might actually either help you do better on your unimplanted ear so that your bimodal outcome is better, or might say you don't actually need a cochlear implant yet, but we'll see you later. Okay? So this is the problem I've seen over the years. We need a name for our guy here, but an Army veteran, and this is a pretty typical VA hearing loss. The asymmetry is nothing to worry about. It's called shooter's ear, and we know it's nothing to worry about because look at the word rec. The word rec is completely symmetric, right? And we just slap a pair of hearing aids on, we let the manufacturer decide which algorithm they want to use, and this person says, I love my hearing aids, and our AFAB on the bottom, green bars are unaided. The higher the bar, the more difficulty they have in moving across, quiet, reverberation, background noise, and aversiveness of loud sounds, and the blue bars are after they got their hearing aids. So they got fantastic benefit. After they got their hearing aids, they almost have no problem in any situation, and they're super happy. Cool. Low complexity hearing aid fitting. 4 years later, he comes back and he says, can you adjust my hearing aids? And you test him, and he's like, his hearing levels went down. That's why he wants the adjustment. But you bring him back for a follow-up, and his benefit with hearing aids is less because the blue bars are now higher on the AFAB. His word rec is worse. What does that tell us? His inner hair cell integrity is beginning to degrade. Right? Now, it could just be, hey, maybe his audibility went down and therefore he's got a little auditory deprivation and he'll get that back and no more you have to worry about it. These AFAB data were like 6 weeks, 8 weeks after the fitting. So we took care of that. So he has more difficulty without hearing aids and he has more difficulty with hearing aids. All right. 4 more years go by and he says, bless you. He doesn't say bless you, I say bless you, but he says, I hear, but I can't understand. I will argue that when cochlear implant candidacy was 20, 30, 40%, this was an early warning sign. Now that cochlear implant candidacy is 60%, this is make an appointment. Not to go into the middle of the plains to some subspecialty clinic. Make an appointment to come into my office and I can do a cochlear implant screening. Okay, because this person no longer has enough inner hair cell integrity to resolve speech. And particularly speech in quiet is an easy task. It's I don't know if anybody's a musician, it's a 3-note chord. It's only 3 formants. You can't do that, you're in trouble, right? Look at his word rec. Look at his aided word rec, right? Terrible. Look at his AFAB. Horrible. He's one of the 12%, he's one of the 88% now. He's failing to thrive with hearing. So in Long Beach, we had a cochlear implant clinic. And once I got there and started looking at it, I said, no, we need a failure to thrive with hearing aids clinic. And I think that that's the new paradigm we as audiologists need to start to think about, with cochlear implant candidacy being as high as it is. Failure to, you're either thriving with hearing aids or you're not. And if you're not, we have a whole bunch of other stuff we need to do besides let one of the big five decide which mutilated version of NAL they want to use in their hearing aids. Okay. So, we're going to do a quick terminology review and then we're going to dive into some stuff. And if I make terrible mistakes, jump at me, okay? All right, CNC words. The cochlear implant candidacy has really been kind of interesting in its evolution. We used to do words and then we did sentences and now we're doing words again. There's a lot of reasons for that. There's a lot of research for that. That's a whole other talk. But CNC words are things like goose, wreck, shore, one-syllable words, consonant, nucleus, consonant words. There's a bunch of different good recordings out there. By the way, recorded speech, always, every time, even for your SRT, please. Thank you. DSL is desired sensation level. DSL and NL2 are your two universal fitting formula. When you plug that audiogram into your, yes, you're using probe microphone systems, yes, okay. I love it when somebody says, oh, I audio scan them. You perform probe microphone measurements to verify audibility in situ against a standardized formula. That's what you do. That's doctor talk. I audio scan them, that's dispenser talk. Okay? We have to be careful of how we speak because it's important. Anyway, these two formula are essentially the same in their intent, which is maximum audibility for the majority of the speech spectrum at multiple levels, soft, medium, and loud, with verifying that we have comfort for loud sounds. The difference is NL2 has a little bit of a roll-off, so we have more of a comfort with audibility, and DSL is what we put on kids because we're like, those brains are plastic, we can blast them all day long. If somebody comes into your office and they've had hearing loss their whole life, they probably have grown up on DSL. Don't change it. There's no good reason to change it. Likewise, if they grew up in Australia and had had hearing loss all their life, they grew up on DSL. Don't change it. Leave it alone. Okay? Because both of them, when properly implemented, do that. But all the manufacturers have their own version. We have this, because those versions modify this even more so the person doesn't go, wow, that's loud, I want my money back. So how do we solve that problem? Well, what we do is we fit them to target for real, and then they go, ooh, it's too loud. Okay, every fitting software allows you to reduce the output and then set a timer called auto acclimatization so that they can come back and in 5 or 6 weeks, it's already back to target. You don't have to bring it back every week and go, okay, we're going to give you a little more, a little more, a little more, a little more. We did that 100 years ago when I was practicing, when I was in graduate school. We don't have to do that anymore. Technology, right? Okay. All right. So here's the big problem we have. We're going toward a concept of best aided condition prior to doing our cochlear implant assessment. However, best aided condition is not defined by anybody except our individual clinics. So there's not a universal definition of it. There's tools like frequency lowering. How many people use frequency lowering on a regular basis? Okay. Do you use it because it gets turned on automatically, or do you have a logical, if you have a protocol in your head or in your clinic book that says this is how and why we use it, that's great. For those of you who didn't raise your hand, it's a way of capturing information in a higher frequency range and then somehow representing it at a lower frequency, either by compressing it proportionally or translating it down. There's a bunch of different versions. They all do kind of sort of the same thing, but you have to actually measure the effect of it. You can't just turn it on and walk away. Okay. So, best aided condition in my book is they meet the whichever NAL or DSL target plus or minus a couple of dB, right? If the tube is so tight, the ear mold is so tight that we're getting unavoidable tube artifact. In addition to doing that, I will also do in situ audiometry so that I have two different versions of what is getting through that ear mold. Then I use recorded speech for everything. ISTS is the one where they mash all the different languages together. You can use carrots, you can use Rainbow Passage, it doesn't matter. And I do aided PB Max. For real PB Max. Remember PB Max from the Katz book that nobody does, where you do multiple levels? That. When your patient says, I hear but I don't understand, you are now in a different world. You're now in, you gotta do it right, or don't bother doing it at all. So you have to find their PB Max. You can't go, oh, 68%, that's pretty good. No, because it might be 68, it might be 88, it might be 35. Plus or minus 5 dB in either direction. And each one of those tells you something else about how much that person is thriving or not thriving with hearing aids. Okay. So you're like, that's cool, great, wonderful, but how do I find people in my database? Because I don't have a tool for that. Anybody here have NOAA in their office? Did you know that you can search NOAA by hearing loss? Huh? Sure. If you go into the advanced search, there's a tab called hearing loss. And you can say, well, you know, this is not perfect, but if somebody's threshold at 2,000 hertz is worse than 70, there's a very high likelihood that that's a dead zone. Remember ShookNet and the cytocochleograms back in the day? If we look just as a screen at all the people in our NOAA database for whom the threshold at 2K and beyond is 70, that gives us an idea of somebody we should take a look at. It's not a cochlear implant evaluation. We're not determining candidacy. It's a screening. Okay? Now, while we're talking about it, if you have a person who says, I hear but I don't understand, there's very high likelihood their high frequency inner hair cells are not very good, and therefore the chance that their threshold at 3,000 is worse than 40 is very, very high. Would you agree with that? What happens when your threshold at 3K is greater than 40 dB HL? Does anybody know?
Yes.
Huh?
But 40 was the demarcation originally, like outer hair cells.
Not really. Well, yes, but that's not what I'm talking. You will no longer be able to hear a smoke alarm well enough to wake up. A standard piezoelectric smoke detector that you buy at Home Depot has a 3,100 hertz tone, and even at 90 dB, it will not be sufficiently loud enough. It has to be 40 dB greater than your threshold to wake you up reliably. So all of those people are at increased fire death risk. When we did that analysis in Long Beach, California, we found 4,800 patients in our database that were at increased fire death risk. So just when you're using your NOAA tool. So here's my bottom line. No disrespect to anybody who has made this their career, who specializes, who does kids, who does any high complexity stuff, but it ain't rocket science. We're talking screening. Remember, I'm not talking about a full-fledged cochlear implant program. What are we asking you to do? I'm asking you to make sure your hearing aids are fit well. Is that something that you can do? Right? You better, otherwise you need to give back that IUD. Can you adjust a hearing aid parameter such that and do multiple aided word lists so that you can optimize the hearing aid performance? Yeah, you can do that. Right? And then, can you put a patient in a very specific spot in your booth? You probably have a piece of tape on the ceiling anyway. That's the spot, right? That's a meter from the speaker, 0 degrees azimuth, 0 degrees elevation. That just means the hearing aid microphones are pointed at the center of the speaker, and they're not too high and they're not too low. Congratulations, you're now in calibrated position to do a cochlear implant screening, right? And you can ask your audiometer to produce whatever speech signal you're going to use at 60 dB SPL at the patient's ear. When you get your calibration, ask your guy to do it and give you the offset. You'll have a sticky note, you put it next to your audiometer, and you say 62, 47, whatever it is. Since we're talking about a cursory screening, you can use your smartphone, I don't care. A 2 dB, if you buy a smartphone $12 or $15 paid sound level meter, it'll be accurate to 2 dB. This is close enough, okay? So then we're gonna put the patient's hearing aid on their right ear, and if their hearing is good, put a masker in the left ear. Do right, do left, do binaural. If you really want to get fancy, do some background noise. That's it. That's the skill set to screen to determine somebody is in the ballpark or not. Because they're probably going to either get, I don't know, 70 or 80%, and therefore they're not a cochlear implant candidate, or they're going to get 60 or worse. If they get 60 or worse, you're going to refer them. These QR codes are also in the handouts, right? The ACIA, that's an independent group. Each manufacturer has a find a clinic, find a surgeon, find a somebody. And this one is amazing. This is the Balcony online cochlear, learn everything you want to learn about cochlear implants. This is not going to take the place of actually working in a clinic, but boy, it'll get you close. You can download test materials, you can download research, there's all kinds of training stuff. And what's nice about this is they didn't just say this is for doctors or audiologists, this is for everybody involved in this. So if you're in a metropolitan area, there's probably 4 or 5 places that already do this. So your job is to find the folks who are starting to fail and scoot them over. Send them to this guy, right? But if you're in the middle of nowhere, you might be it, right? You might be it. And we've tried a whole bunch of ways to do this. Most of the ways we've tried have been driven by manufacturers. The Cochlear Provider Network is one of the ones that most people hear about. They're the ones that make the little magnets that you stick on your your booth, and then you see it, and you see it every day, and then it becomes part of the paint of the booth, so you don't see it anymore, right? There's been a bunch of presentations looking at different ways to do this, and the VA claims that they're now mentoring some of those 1,300 audiologists. I haven't seen any data on it, and they wouldn't give it to me, so I have to wonder whether it's going yet. Maybe it is, maybe it isn't, I don't know. But here's the thing. Everybody now in the cochlear implant world is chomping at the bit saying, will you please refer people? There's a lot of people out there that meet this 60-60 criteria. Please, please, please send them to us. And there's one group of people standing in the way of this, and that's us. That's the cochlear implant audiologist. Because you're the people who are supposed to, we are the people who are supposed to know better than the dispensers. All right. Why haven't we really done it? Well, here's the thing. There's no standardization in any of this cochlear implant stuff, which is kind of ridiculous because the FDA really crawls up there, you-know-what, of these companies every time they want to make a new processor. But there is none. Now, then you say, well, fine, I'll consider a cochlear implant. And you start looking at the research. And the research, it's not superstar research. The average outcomes are not that good. And we have to wonder why the outcomes aren't that good. Well, first of all, we have some problems with data. Does anybody see a problem with data in this slide? N of 20? Are you kidding me? N, I mean, come on. Come on. Samsung has bigger subject numbers when they make a new earphone. All right? All right. We don't force people to do anything in audiology. Oh, you do it the way you want to do it. It's okay. No. For about 6 months, I helped a friend of mine, and I worked as the front desk person at a tattoo parlor. In those 6 months, we had 7 or 8 visits from the health board. We had 7 or 8 visits from 3 or 4 other agencies that regulated our ability to poke a hole in somebody's ear and draw a terrible picture of a penguin on their rear end. I've been practicing audiology since 1992 in about 14 different states over those years. I have yet to have anybody from an audiology licensure board come in my office and see if I know what the hell I'm doing. The honor system is not good enough. So we don't force any. Even in the VA where you have mandatory training, that would be super easy. Basic cochlear implant stuff, nope, we don't do it. So again, there's an internal desire to keep the status quo, but we have to take a little bit harder look at that. When everybody who got a cochlear implant was by definition a high complexity patient, that made sense. I don't know that that's true anymore. All right, so we have another problem with data. And in this study, there were 200 articles looked at. 99 of them had less than 10 subjects, but yet they were peer-reviewed and published. I'm sorry, I don't care. Now, well, every excuse I hear, well, you know, we're kind of a small room, it's hard to recruit people, then let's stop being subspecialty, remote, isolated clinics. Let's do what every other technology in healthcare system does and do multi-site research and get our IRBs together in the room and hash it out, because there's nothing that's that different. But that's the excuse. We have all kinds of excuses why we can't do it. We also have 70 plus AUD programs, and we'll probably need 10. Can you imagine if we had 10 AUD programs and each clinic was so big that they were the destination for their area, and each student had 1,000 or 1,500 hours every semester of clinical access instead of 5? Wouldn't that be kind of cool? Okay, so we create our own problems. All right. So it's not that we have a problem with the implant. It's not that they're scary. It's not that patients don't want them. It's that we persist in maintaining a system that has very poor access for the majority of people who need the service. Okay, so I hear this all the time. Oh, cochlear implants are hard. You have to be a specialist. So let's take a look at why that patient who finally gets to the cochlear implant specialist is hard. Because in my clinic, they start to fail to thrive with hearing aids. They're having problems. So I make an adjustment. And they go, well, that seems better. But I'm the kind of audiologist who doesn't measure anything, so I just say, how does that sound? And they go, it sounds better. Because they want it to sound better. And then they're still failing to thrive with hearing aids. And so we get them new hearing aids. And now they have a good motivation of $8,000. It really must sound better. And I've sold them like the rep sold me. And we go into this loop. And they never get out of this loop. So we might spend 5, 10, 15 years doing this. What's happening to that person's basilar membrane in 15 years? Is it getting better? No. How about their brain? Is it getting younger? No. How about their ability to withstand about 2 hours of general anesthesia? Is that getting better? No. Finally, we make the referral. Okay? Okay. Oh, I just said all this. Okay. And the problem is now I send, what's your name? I'm going to keep pointing to you. I'm going to ask. Connor. I'm going to send Connor my referral. But now I have created in my patient long-term auditory deprivation for about half of their cochlea, and therefore half of their auditory cortex. And so, unfortunately, Connor's not close to me. Maybe he is. I don't know. Where do you practice?
I'm in the Bay Area.
You're not close to me. So my patient has to travel far, but it's worth it because Connor's good. But that becomes a logistical challenge. He's also very busy, so getting that patient in is tough. And therefore, my patient is even older when they finally do the implant. Because they're even older, their auditory plasticity is a little slower. So they need more follow-up, which is really hard because then they got to keep going to the Bay Area for that. Maybe we do some telehealth, that'll be nice, but still, they're going to need a lot more. And their asymptotic performance is going to be on the low end. So when that person gets plugged into the research, they're going to pull the mean down. But when this is the mean, then the mean is down. So when somebody says, well, I'm getting 60% with my hearing aids, and the average is about 73 with cochlear implants, I don't think it's worth it. Now, I can't predict that if I had gotten that person to Connor 10 years earlier, that their asymptotic word recognition and quiet would be 88. But based on my experience, yeah. And that person's complications, the trajectory, some of the veterans that I tracked and got into the pipeline when they first started having problems and their aided word rec was 72, that's when I started having primary care prep them for surgery. Because last year it was 84, and the year before that it was, they're not getting better. So if we wait until they meet criteria to do all the stuff that's required to get them surgery, we're adding time. So by the time these guys met criteria, they were ready to go. And they went and we got them implanted at 65, 66, 67, and they had very steep asymptotic growth. So it was really not hard to do, but it's important to do. Okay. So how does this work? At a bare minimum, the person who works with this person all the time, their audiologist, and I'm even going to argue, this is going to make everybody mad, a hearing instrument specialist can be part of this process. Okay? They screen. We're not talking about doing screening. Okay? We let somebody with an associate degree or less screen our babies in the hospital. We do that. It's not a big deal. They don't have to be an audiologist to do this. Why? Because hearing instrument specialists also do hearing tests. And they can be trained to do this. And you can be a partner in this, right? Okay. In an ideal practice, everybody who's an audiologist can screen for cochlear implant candidacy, do an actual evaluation in coordination with their local or closest surgeon, whatever their criteria is. They can do the initial activations, and if it turns into a complex case, they can reach out to a specialist. But if it's just a run-of-the-mill thing, and you get them early, and everything is going well, you probably can incorporate this into your practice with a lot, and there's support out there, the manufacturer, everybody's going to help you, right? You just have to ask, right? So we can do all this, and you can help the next generation do it too. That's the idea. And you're like, great, wonderful stories. Thank you for telling us fairy tales, Brad. We appreciate this. Well, here's money where my mouth is. In 2012, I worked for a hearing aid dealer. I needed a job, and he had a job. And there were 2 audiologists in that practice. And both of us did cochlear implants. And I called us hybrid audiologists because if you walked in and you had a cochlear implant, we did a cochlear implant evaluation. If you walked in and you had a hearing aid, we did a hearing aid. If you had one of each, we did one. It doesn't matter. There was no demarcation of cochlear implant clinic, appointment, whatever. We just did what we had to do. We did evaluations. We had a local surgeon. He said, this is my criteria. I said, okay, fine. Let's build a protocol. Bing, bang, boom. We did it. We did activations. We did follow-up. No big deal. It was what it was. Okay? Did we have higher complexity folks? Absolutely. Did we coordinate with a local bigger center? Yeah. Sometimes we referred folks to our local con, right? All right. In 2014, I took over the audiology and speech language pathology department at the New Mexico VA. In New Mexico, there's one audiology department for the whole state, 5 audiologists when I got there, and part of Colorado and part of Texas. They had a neurotologist who came in to do surgeries, but he was a busy neurotologist. And he only did 6 implants a year. Now, those 5 audiologists saw between 12 and 1,500 patients a year each. Is it reasonable to assume that only 6 of them needed cochlear implants every year? No. So here's where we get to, do we need a neurotologist? He said, absolutely. I said, I don't know. So I went to the chief of ENT and I said, when was the last time you saw cochlear implant surgery? And he says, in medical school. I said, let's go online, shall we? And we watched a couple of cochlear implant surgeries. And I said, look, here's the bottom line. You guys can do a stapedectomy? Oh yeah, I can do a stapedectomy. You're halfway there. So the senior of the 3, who's an otologist, not a neurotologist, happened to go to school with Dr. House out in California. So he said, I want to go hang out with my buddy. So he went and he stuck his head in a surgery for about a week. And he came back and he said, boys, we can do this. So the 3 of them went on a 6-month journey, intensive training, bone labs, all 3 manufacturers. They did 75 implants the next year. One of them is a DO. Not even an MD. His outcomes are equivalent to the neurotologist over the last 20 years, whatever. Why? Because we were getting people sooner, faster. Now, when the crazy ones came, the ossified ears, the neurotologist did those. But the vast majority of them were non-modified cochlea. They were just old guys with bad ears. Okay? Then I went over to Long Beach, and at the time we had a CI audiologist. She was very proud of her title. And nobody knew what she did, because she made sure nobody knew what she did. And she had 2 appointments a day, because she told everybody that every cochlear implant appointment must be 3 hours. And I said, based on what? Where's your data? She didn't have any data. We had a little conversation, and she quit. And then they said, here, you can have the cochlear implant program. And I said, then you got to get out of my way. And they said, what do you mean? I said, did you know that there's another audiologist that you just hired who has 5 years of cochlear implant experience? And they go, really? So you didn't bother to ask him? No, because we have a cochlear implant audiologist. So now there were 2 cochlear implant audiologists. But we practiced like I practiced back with the hearing instrument specialist. I don't care. Just walk in. It's not a necessary. If I'm doing an annual audiogram and I start to see things go south, I'm going to convert that to a cochlear implant screening immediately. No new appointment, no extra, just like boom, bang, boom. Okay, we're going to do aided word rec. We're going to optimize your aided. Come back next week, come back in 2 weeks, and we start to track these folks. So then it turned out we hired another young audiologist. And guess what? He had cochlear implant experience too. So now we had 3 hybrid audiologists, which means if we needed to, we could see 18 cochlear implant patients a day instead of 2. Now, to make it more interesting, we were the only surgery center in Southern California. And I don't mean like Southern California like LA, I mean like the southern half of California. And it turned out that there was an audiologist in San Diego who had cochlear implant experience before she joined the VA. And I heard about her, and I called her up. I said, hey, I'm going to send you a form. Fill this out, and then you're going to become a programming center. So there's a way that we can build cochlear implant capacity without denying the benefits of specialized cochlear implant care. But remember, we're really talking about only serving that minuscule group. Okay, how are we doing on time? Ooh, I'm going to hurry up. All right, so can a hearing instrument specialist be part of this? They can. Here's why I know this. I've taught people who are hearing instrument specialists to do better audiology than a lot of audiologists do. We know based on surveys that about 30% of us even bother to do probe microphone measurements. If you believe the stuff in the textbooks, that means that you're not practicing at the top of your game. But I trained a hearing instrument specialist how to do this, and this terrible, horrible miracle ear guy had 50 locations, and every single one of his fittings had probe mic And it was basically the AAA protocol that I gave him. Otherwise, he wouldn't pay commission. So we can do that. We can add to this, and I did this in 2019 in a large ENT group. And a specialist, she did my protocol. I did the high complexity patients. She did the low complexity patients. I did 15 hearing tests a day. We referred about, based on our population, about 85% of those got hearing aids. In 6 months, one of them was high complexity. Here's why it's important. This is the projected growth of hearing loss between now and 2023 or 2032 worldwide. And everybody says we have a problem, we don't have enough audiologists. If we allow hearing instrument specialists to do the majority of low complexity hearing aid fittings, this is the rate at which they're growing. So there's plenty of coverage for low complexity hearing aid fittings. And we can cooperate with them and get them to understand when it's time to send them back to us for the higher complexity stuff. But then we say, you know what, but here's the thing. Part of audiology is balance. And we don't have a lot of time to do this cochlear implant stuff because we're busy doing balance. Well, we do the balance and then we refer them to who for therapy. Why can't they do the diagnostics too? They actually have more people than we do. And they have a doctorate too. So, okay. Here's the problem. It's really important that in my audiology practice I do cognitive screenings. Because the Lancet article, not the first one that got rejected, but recalled, the second version. But when I have a cognitive problem, where do I send them? Oh, I send them to the speech-language pathologist. But here's the problem. If I do all these cochlear implant screenings, there's just not enough surgeons to do it. And the doctors around me, they don't understand. They just don't understand cochlear implants. But this is the number of doctors who have completed ENT residency. So if we do a little bit of hard work, there's a lot of knowledge and there's a lot of awareness out there. But here's the big problem. You ready for it? This is our projected growth rate as a profession. We don't have time to do anything other than high complexity hearing loss. I'm sorry if you like balance. We don't have time. Okay? Now, here's the thing. Most of the hearing loss out there is mild to moderate. Maybe just outer hair cell loss. That's a walk in the park, man. In fact, we even know from the Lexi study, you don't even need a human. You don't even need an audiologist. You get the same outcome with a mild to moderate hearing loss with the app. That doesn't mean that we're not important. It means that we're focused on the wrong population, right? These guys, that's where we need to be focusing, moderate and severe. Now, look at this. That's a lot, that's worldwide. That's a lot of people who possibly need cochlear implants, and we're spending all our time with the baby boomers and the easy fit hearing aids. Now, what happens when you get a hearing aid? Well, if you're young, you have no more problems. Green bar, percentage of people who had no difficulty after getting hearing aids. So the traditional model works fine for them. In fact, OTC may work for a lot of them. The red are the really terrible hearing people. Those are the people in Connor's clinic. That's the traditional model. High complexity, really severe hearing loss. Lots of problems. But as people get older, they start to have more residual problem with hearing loss, with hearing aids, i.e. failing to thrive with hearing aids. Do you remember our trajectory? We don't even have enough people to cover them. And we're spending all our time in the green. The grass is greener over there, the money is better, but that's not where the need is. All right, I love SWOT analyses. The traditional model is amazing because we have specialized expertise. We have usually multidisciplinary clinics or access to them, and we can do longitudinal studies if we care to. The proposed model has the strengths that we know our patients, we know their hearing loss trajectory, right? They're local, we can get them in faster, and they can have shorter durations of effective deafness. With the traditional model, we've talked about this. A lot of times they're limiting in terms of access. And they may or may not be up on new hearing aids, and they don't know our patients. They just don't. We think that we're going to lose business if we refer somebody to a cochlear implant clinic. Believe me, they're busy. They're so busy, they don't need our patients, okay? The opportunity, though, is in the traditional model, we could do a lot more to standardize the process if we choose to. All right, we could mentor, we could actively reach out to the audiologist 50, 100 miles out from our clinic and say, I want you to become an expert so that you don't have to send those people to me. We could do that. All right? We could, and so the opportunity for us as private practitioners is to expand our scope of practice, our services, not in terms of reaching out beyond audiology, but reaching in and going deeper in what we do, right? And the problem with it that I see with the traditional model is it just takes people too long to get there, and their effective deafness is longer, and their outcomes are slower and worse. And they're older. I don't want an 87-year-old guy on the table if I could have gotten him on the table at 68. I just don't. Okay. There's the over referral scarcity model only exists if we only refer to those 400 neurotologists. If we let those neurotologists work with ENTs and otologists who are already doing middle ear surgery and help them come along and identify the lower complexity patients by radiography, then we can open this up and have, and anywhere there's an ENT, there's somebody who can do a low complexity surgery. All right, so how do we make it less bad for now? I'm going to whip through this because I'm running out of time. In Long Beach, we started looking at where the frequency lowering default was by the manufacturer and whether it was in the right place. And basically, we just did NU6s, aided, and moved the knee point around. Anywhere there's an asterisk, that's a standard deviation or more of improvement. This is in the appointment, a 30-minute appointment, not with training. So these people are going from 52% to 88% in 20 minutes, just because their hearing aid wasn't programmed correctly. Okay, now, there's a long-term risk of this. If you have frequency lowering for 30 years, you're actually not stimulating that part of the brain anymore. But this is a stopgap so that we can get them to the cochlear implant, and they can function, and their non-implanted ear functions better. 18% average improvement, not too bad. When we look at their AFABs, they're getting statistically significant and then some improvement in access to sound and hearing and background noise. Right? Don't do domes. If anybody says, I hear but I don't understand, immediately make them an ear mold. On the right-hand side, improvements in speech and noise. The green is the ear mold. The standard deviation on this particular test is 1%. So they're going from 58% in noise with a dome to 76% with an ear mold. The dome doesn't allow the position of that speaker to be where you had it when you did your probe mic, and therefore you can't count on it. But if you have an ear mold, it'll be there, okay? Ear molds are not based on dB. Ear molds are just better. All right. Remote microphones are not accessories. I don't care what the order form says. If this is old data, but it's still relevant. If you're relying on ear level microphones to provide beamforming, and a person has a hearing loss, they're probably going to max out at around 60-70% in noise. But if you give them a remote microphone, you can get them up to 24 dB signal to noise ratio, and that's where they need to be. That's a component of their hearing system. None of this takes them out of cochlear implant candidacy, but it gets them functional or keeps them functional until we can get them along the road. Okay? Here's the bottom line. You all have these people in your database. You know you do. You just avoid them and hope they don't come in. Not because you're bad people, because you don't have the tools to help them. Their cochlea is so beat up that amplification doesn't make it better. It used to make it better. Now it makes it less bad. And at some point it gets so less bad that the only thing you can do is give them a different system. Cochlear implants are not a different system. They're the end of the trajectory for a hearing aid patient. That's your doctors. You're supposed to be doing all of it. Okay? All right. Now, here's the real sales pitchy thing. When they say I hear but I don't understand, it's already probably 5 years after they should have been screened and evaluated. If you're in his backyard, do screenings and send them to him. If you're more than 100 miles from the local Connor, get with them, get with the manufacturers, get your practice squared away so you can do a screening and an evaluation. You might not do the initial stimulation, you might never do the programming. That may all get done remotely, that's fine. But they can't help, the surgeon can't help unless you send the patient there. Right? We're doctors now. We have a responsibility to treat the entire spectrum. Okay? Everybody else uses mid-levels, but we don't. Right? Physicians use nurse practitioners and PAs. We have audiology assistants who can't do anything that we don't tell them to do. So they don't really help us that much. But we could use hearing instrument specialists for low complexity work. Don't make it a competition. Hire them. Put them in your practice. Make money off of them. What's the big deal? Let them do the low complexity stuff. Give you time to do the high complexity stuff. Make sure you don't miss people. Because here's the bottom line. This is what your insistence on low complexity work is. That's 88% of people walking around like that. Because we have decided that only 12% of people are allowed to get cochlear implants. That's it. Thank you very much. I'll take questions if they don't kick us out. Look at that, I finished in 2 minutes early. You have 2 minutes for questions. Go! Yes.
Do you tell your patient you're doing a cochlear implant evaluation, or do you just move into that test and say, hey, pop your right hearing aid in and get them set up?
Yeah, all I say is, hey, your hearing seems to have changed. We're going to do some additional testing to better identify how well you hear. And then if I find out that they are a cochlear implant candidate, I say, so let's have a conversation about the next technology that might help you hear better. It's not a new hearing aid. I'm not going to sell you a new hearing aid. Here's why. Because I think when we say, I'm going to send you for a cochlear implant evaluation, we have now created a big deal. And they're like, I don't want the surgery, so I'm not going to get the evaluation. I don't care if you get the surgery. I mean, I do, but I don't. The point is of a cochlear implant evaluation is to determine whether they meet criteria, period, the end. You know, in a medical center, I see the patient, I establish audiologic criteria. I hand them off to primary care. I'm done until they come back for device selection. They do all their primary care stuff, get ready for surgery, whatever. They meet with the ENT, they have their scans, they do all that stuff. I don't need to be involved in any of that. They say, yes, I want to get a cochlear implant. Cool. So now they meet audiologic criteria, they meet medical criteria, they're motivated to move forward. Come back to me for half an hour, I'll show you the difference between Advanced Bionics and Med-El. If I even have a choice, because maybe my surgeon only does one and it doesn't matter. Then it's like, what color do you want? Okay, cool. Then I fill out the order form, and do I have to fill out the order form? Maybe my assistant can fill out the order form. Maybe AI can fill out the order form. Maybe Google could be listening to this conversation and be filling out the order form, right? Because I need my doctorate to fill out an order form. Then they go and they get their surgery. Do I have to be there holding their hand? No, I don't. I really don't. It's nice. It makes me feel good if I do, but I don't have to be there. Do I even have to be in the operating room? No. Do you know why? Because there's already an electrophys tech in there. And I can give them a little thing and say, here, when it comes time, push the button. and show it to the doctor. He's like, oh yeah, good, we're good. But now they're doing it with CTs and all. I don't know anything about CT scan. I don't need to be there. I add no value to put my jammies on and go into the operating room. I feel good, but it doesn't help the patient get a better outcome. Because there's better people already there. And operating rooms are crowded, and every time I'm in there, I might touch the wrong thing.
Additional time spent, if you're just doing an annual evaluation, you identify this.
Okay, so it takes me 14 minutes to do 92557, and then it takes me 2 minutes per list to do aided word rec. So I can do a cochlear implant candidacy evaluation in 20 minutes, maybe. Just audiologic candidacy, not all the other stuff. Then I'll bring them back and we'll have a conversation. But 9 times out of 10, if it's not a long-term patient of mine, I need to do some hearing aid optimization anyway. When I do that, I'm going to send them away and bring them back in 4 weeks to see how it took. And then I'll do those evaluations again, and that's when I'll do my formal candidacy evaluation. And that's an hour-ish. My initial activations are about 45 minutes, and then my monitoring stuff after that's about 30 to 45 minutes.
So you would book a standard evaluation based
Yep.
about the screening, hearing aid.
Not really. What I would do is I would book them in for an annual evaluation. He'd be on my book for half an hour. In that half an hour, I would determine we have a problem. I bring them back for another half hour to do the optimization on the initial, is he a candidate? If he needed optimization, I'll bring him back for like a half an hour or an hour in a couple of weeks. And then that's it. I mean, the actual testing doesn't take very long. It really doesn't take. If you're doing Easy Bio, it's 4, 5, 6 minutes, something like that, a list. It's not that long. If you're doing CNCs, it's a little longer. But, you're talking about half hour, 45 minute, maybe an hour appointment. But how many times is that guy going to come back? I hear, but I don't understand. Can you make an adjustment? Can you make an adjustment? That never, ever, ever gets any better. So when you look at the aggregate, spend 2 or 3 hours aggregate up front and get it done right. And then get them where they need to be. How do I do, Connor? Okay, I was worried. You're hard to read. You're good at poker, aren't you?
No.
Yeah, you should be. You should be. Okay. Any other questions? I'm going to be around for today and tomorrow. I'm going to be hanging out at the AB staffing booth. I'm happy to talk more. The handout that you guys have is a little dated, but this talk will be on YouTube eventually, and I'm not hard to find. Pain in the butt audiologist, it's first organic Google search term. All right, thanks very much. Have a good rest of your conference.